Another important topic you face sometime when you at the time of induction or at the time of extubation, and it just tests your nerves because the time with you is limited and you have to manage with the available resources, and the Dr. Jyoti Sharma would do the justice to this topic. I request Dr. Jyoti to share a screen and proceed with her lecture. Dr. Jyoti, please.
Good morning, sir. Uh, Thank you so much, sir. I am very delighted to have you as a
very
chair.
warm welcome to all of you. First of all, I would like to thank the organizers of APPEC2023 for giving me this opportunity to be a part of this academic feast. I will speak on the topic laryngospasm, which is a very important topic not only from the exam point of view, but also in the clinical scenarios where in severe cases it can be even life-threatening. So we'll go about by introduction of laryngospasm, the statistics, pathophysiology, and to understand the pathophysiology, we'll touch upon the nerve supply of the larynx, risk factors associated with laryngospasm, the prevention, and the management. So what is laryngospasm? It is a reflex glottic closure due to activation of glottic musculature. It is a protective airway mechanism to protect from tracheobronchial aspiration. It is usually activated during the excitation stage of general anesthesia, and definitive diagnosis can only be made by visualization of the glottis. So it is characterized by severe hypoxia in 61% of cases. In approximately 6%, bradycardia will occur, obstructive pulmonary edema in 4%, cardiac arrest in 0.5%, pulmonary aspiration in 3%, and arrhythmias and even death can occur in severe cases. So coming on to the nerve supply of larynx, the sensory supply above the vocal cords is by the internal laryngeal branch of superior laryngeal nerve, and below the vocal cords by recurrent laryngeal nerve. The motor nerves are supplied, all intrinsic muscles are supplied by recurrent laryngeal nerve except the cricothyroid muscle, which is supplied by the external laryngeal branch of superior laryngeal nerve. So the periglottic stimulus is mediated via the vagus nerve. The sensory fibers from the laryngeal receptors may be mechanical, chemical, or thermal. They ascend via the vagus nerve, via the internal branch of the superior laryngeal nerve. The highest density of these receptors exists posterior to the true vocal cords, where the foreign bodies are most likely to spill over while airway management. Now coming on to the motor supply, the motor response in laryngospasm is mediated by the adductors and the tensor. The adductors include lateral cricoarytenoid muscle and the thyroarytenoids, and the tensor, the cricothyroid, is the only tensor of the vocal cords, and the motor response, all of these are supplied by the vagus nerve. So the glottic closure in laryngospasm can occur by the closure of only the true vocal cords, or it can occur in adjunction to the closure of false vocal cords also. Now let's see the picture. On the left side, the larynx is relaxed. Larynx has relaxed vocal cords, while on the right side picture shows the same larynx in laryngospasm. The event that occurred while taking these pictures in between was the endotracheal tube was being inserted, and it touched the vocal cords while the patient was in a light plane of anesthesia. That triggered laryngospasm. So the movements that occurred included the closure of the vocal cords, both by pulling them together as well as by tensing them, the closure of the false vocal cords, the mounding of the paraglottic tissues by elevation of the larynx, which included the lower epiglottis, paraglottic fat, and base of the tongue, and also the folding of epiglottis over glottic opening. So coming on to the risk factors for laryngospasm, they can be divided into anesthesia-related, patient-related, and surgery-related factors. The anesthesia-related, most important is the insufficient depth of anesthesia, as we have already discussed. Next include airway irritation with inhalational agents, mainly isoflurane and desflurane. Then sodium thiopental because it does not blunt airway responses. Next, the secretions which are induced due to ketamine, and the insertion of laryngeal mask airway, which has more chances of laryngospasm at induction than endotracheal tube, while at extubation, the endotracheal tube has more chances than laryngeal mask airway. So the patient-related factors, mostly the children are more commonly affected than the adults. The upper respiratory tract infections, if it occurs within the past 1 month, ASA class 3 or more, children with airway anomalies, chronic smoking, which also includes passive smoking, gastroesophageal reflux, history of choking at night or long uvula. Then surgery-related factors, the airway surgeries, that is the tonsillectomy and adenoidectomy, are most commonly at risk. Other surgeries at risk include appendicectomy, genitourinary surgery, thyroid surgery, and esophageal surgeries. So what should be the clinical approach if we encounter laryngospasm? First and foremost, we should try to avoid laryngospasm, postpone some elective cases based on history of URI or some other risk factors. Then take adequate measures to prevent laryngospasm. Then if we encounter laryngospasm, then we have to know the treatment. So while induction, pre-medication with morphine or fentanyl can decrease the incidence of cough by 10% and will reduce laryngospasm. Lignocaine 1 to 2 milligram per kg can work both preventive and corrective for laryngeal spasm. Then magnesium sulfate 15 mg per kg IV before tracheal intubation is also known to decrease incidence of laryngospasm in children. Then if we are doing inhalation induction, then we should prefer sevoflurane or halothane, and we should avoid isoflurane and desflurane. And continuous positive airway pressure during induction of approximately 5 to 10 centimeter of water will avoid obstructed breaths during induction. Then while doing airway management, when endotracheal tube is being inserted, ensure that there is adequate depth of anesthesia before direct laryngoscopy. And if the depth is not adequate, remove laryngoscope and deepen if the patient moves or vocal cords are not open. So how do you diagnose laryngospasm? First and foremost, we have to recognize airway obstruction. How do we recognize airway obstruction? There will be a paradoxical motion of the chest wall and abdomen with each respiratory effort. After recognizing airway obstruction, we have to rule out other causes. The airway obstruction that does not respond to the maneuvers, that is the triple maneuver, head raise, chin lift, and jaw thrust, or the insertion of oral airway, that is the diagnosis of exclusion. After that, we have to check if the airway obstruction does respond to deepening of anesthesia and the giving succinylcholine, then it is a definitive diagnosis of laryngospasm. So direct vision of laryngospasm is almost never there. It is mostly a clinical diagnosis with a diagnosis of exclusion. There can be some events that can raise suspicion. For example, the excitement stage of anesthetic, that is the stage 2, the noxious stimulation during stage 2, coughing or breath holding, which often precede laryngospasm, may be seen. Now that we have diagnosed, we have to manage. First and foremost, call for help as the situation can deteriorate at any time. Then immediately apply firm extension of the neck and head, CPAP with 100% oxygen using bag and mask. Now, use of airway adjuncts for better ventilation is controversial and most of the times is not successful. If the spasm doesn't break with CPAP, then give propofol 0.25 mg to 0.8 mg per kg, which helps in breaking the spasm. If that is also ineffective, then paralyze using succinylcholine 0.1 mg per kg. Then we can do the maneuver, that is the Larson's maneuver. Pressure is applied with the fingertips to the area between the mastoid process, the ramus of the mandible, and the base of the skull. And if all these are ineffective, we have to go for emergency tracheostomy at the earliest to maintain ventilation. So this is a flow chart which explains the sequence of events I have already discussed for management. There is also a 7P approach which has been told for the management. You can remember it for easy remembrance. The 7Ps include pause, personnel, that is call for help, position for all the maneuvers and suctioning of the blood and secretions, then PEEP, that is 100% oxygen with valve closed, then pressure point at the Larson's point, propofol 0.25 to 0.8 mg per kg is enough, and paralyze using succinylcholine. So to conclude, direct laryngeal or distant visual stimulation can produce laryngospasm in light planes of anesthesia. Recognition of at-risk patients will help to prevent laryngospasm and avoid potential significant morbidity. Prompt recognition and early correction is essential to re-establish ventilation and oxygenation as soon as possible, and treatment requires opening and clearing of the oropharynx, applying CPAP with 100% oxygen, followed by deepening of anesthesia with propofol and paralyzing with succinylcholine if required. So thank you all for your patient hearing. Any questions can be asked.
Thank you, Dr. Jyoti, for highlighting nerve supply and the various preventive aspects, causes leading on to laryngospasm.
Thank you, sir. Thank you so much.
Well said. Like still, if we cannot go by like 1, 2, or 3, there is very limited time available once the laryngospasm occurs. Okay, so what would be your take home first? Any advice when we are planning extubation? Because now it is said that for every extubation, you should use some kind of technique so that you're safe once the tube is taken out.
First thing is that we should make sure whether we are planning for deep extubation or we are planning for extubation in the awake. So we should never go for extubation in between phases, like the patient is almost either the emergence should be enough or the patient should be extubated in deep plane to avoid any stimulus. Next is that we should, the very important point is we should keep ready the things we would require in emergency. So propofol or succinylcholine, most of the times we do not keep loaded, but it should be available if required in emergency cases. I recently encountered a case of laryngospasm last month only. That was a child of being operated for appendicectomy. Also, I'm so sorry, tonsillectomy. And the saturation dipped within seconds to 50. So within seconds, it was from 100 to 50. So it was like a life-threatening situation. And immediately, the first and foremost is we should recognize that there is some critical event. And most of the time at this, thinking about the situation, the surgery and the time of extubation, it would be most commonly laryngospasm only. So immediate propofol was given, and obviously there was no time to wait that propofol would act or not. So simultaneously, I gave succinylcholine also.
Means that is a panic situation. Sometimes that's what, like I remember many hospitals have, for particularly for tonsillectomy patients, because that is the one area where you are sharing the airway also.
Yes, sir.
They
And sir, there is
give-
the trickling of secretions and blood in that surgery. So
that's why we advise tonsillar position, and even some institutions they had protocol of extubating the patient in the recovery, leaving the tube in situ and then taking it out. So because there can be institutionalized protocols for such cases.
yes, sir.
Really, the laryngosperm sometimes okay, because these are high risk cases. You can say that tonsillectomy or sharing of airway, but otherwise also in some of the cases where you don't have any to look at, there is no apparent cause, nothing is there. Patient is ESA1.
So when there is a partial obstruction, most of the time it gets we can get over it by giving PEEP or CPAP for some time. So,
CPAP, yeah.
yes, sir.
That's what if you make a protocol at extubation, every patient, because some kind of residual muscle relaxant effect can be there, or the patient may not have come out of his conscious level completely. So if we CPAP for 2-3 minutes at the time of once the tube is out, and keeping a mask with some kind of CPAP, you get better results, and the chances of ending with a laryngospasm are less.
Yes, sir.
So, you said that propofol, of course, sometimes we are in a hurry that we immediately, because the saturation is falling so fast, and we push and propofol, then we end up giving succinylcholine. So, second time when you will take the attempt for extubation.
So second time, we'll wait for some time. We'll let the patient awaken fully, have all the reflexes back again, and so sir, it would be like I will not go for deep extubation for the second time. So
Because that becomes very tricky,
yes, sir.
because you cannot
It will depend
let the
upon the situation, and but the CPAP will definitely help. These days, sir, they have described one no-touch labeled as no-touch technique also, in which they that is we are doing regularly, but the technique is named as no-touch technique. When so the bag is pressed before the extubation, and there is a deep inspiration given.
Exactly, yeah, that is quite helpful. In fact,
Yes, sir.
it's to be promising in the coming days.
Just before extubation, we can give a puff with.
So, I think much of the things have been discussed. It's only you learn when you go through your career and see that laryngospasm is actually occurring, and because
First and foremost is to diagnose at the earliest and
that is
don't.
also there. That if you miss the diagnosis, then you are left with you will treating it as a bronchospasm or something else. The proper diagnosis has to be made, because in that case, first treatment would be, of course, CPAP and 100% oxygenation plus the lifting of the jaw.
Yes, sir.
And if some airway conduit is required, or oropharyngeal airway, you can put for providing a clear air, like ventilation or CPAP. You can use some kind of oropharyngeal airway if it can be. So, any chat, I think we can see few questions.
So there are no more questions. There are no questions for this particular
This
lecture.
speaker, they were for the previous one.
They
No?
were for the previous speaker, yes, sir.
Yeah, okay. So we can wind up this session. I think if there are no more, anything to add by our panelists, if somebody is there with us. Both these topics were important: laryngoscopy,
The
video
post-radial
laryngoscope types. Yeah. And of course, laryngosperm is always there when you talk of anesthesia. It can occur any time of your career.
Yes.
Okay, thank you very much. I'm thankful to the organizers for organizing this beautiful PG program for the benefit of postgraduates. Although, but I don't know whether the timing is such that the very few attendees are there.
Sir, actually, this is for the faculty. What you can see, the delegate link is a different. So we have a good amount of students.
Okay,
who
okay.
So they're benefiting from it. Yeah.
This is only for the faculty and attendees.
Yeah, that is just because that those are the faculty, so which are able to see.
Okay. That's fine. Okay, but still, it is like good for all of us to have this
Yes,
interaction.
definitely.
Thank you very much. Thank you, Jyoti.
Thank you, sir. Thanks so much.
Thank you so much for your contribution, sir, for making APPEC even a bigger success in consequent years. And thank you to both the speakers for their valuable contribution. I'm sure the PGs have benefited from immensely from the knowledge that they've gained through these lectures. Thank you so much.
Thank you.
So we'll now go for a lunch break. We'll have our second quiz before we go for the lunch break. Can we have the questions, please? Yeah, so here goes the first question. Which of the following is not a hemodynamic goal in a mitral stenosis patient with pregnancy? A, avoid tachycardia. B, avoid increased preload. C, avoid bradycardia. And D, avoid hypertension. Remember, which is not the hemodynamic goal. Second question, which of the following is the full form of RAE endotracheal tube? A, right angled endotracheal tube. B, Rush-Edison endotracheal tube. C, Ring-Adair-Elwin tube. Or D, Ring-Edison-Eris tube. Thank you, and we'll resume at 1:35 for the next session, for the post-lunch session. Welcome back after the lunch break. We'll just shortly resume in 1 minute. We're just waiting for Dr. Rotela to join us, if you could add. In case if he faces difficulty, maybe he may proceed. Sorry for the inconvenience. We'll just wait for a minute or two for Sir to join as well. Welcome back. I think we'll start with the session. We have one of our co-chairperson, Dr. Surinder sir with us. So maybe Sir can chair while Dr. Rotela can join us. Can we have Sir's CV? The other, Dr. Surinder's, yeah. So I would like to invite the chairperson for this session, Dr. Surinder M. Sharma. Sir is chairman of anesthesia at Medanta Medicity, Gurgaon. Sir's area of keen interest are orthopedic anesthesia and pain management. We welcome you, sir. And I hand over the proceedings of the session to you, sir.
Welcome all the delegates and thank you organizers for giving me this opportunity. May I request Dr. Kapil Chaudhary, who is a professor at Maulana Azad Medical College with keen interest in airway management, simulation, ACLS, BLS, and critical care